everybody. Happy New Year. Thank you for joining us on our first Tuesday chat of 2022. I am Brenda Green with the Be Strong Group, and my husband and I founded this nonprofit in honor of our son, Braden, who has sickle cell disease. And our goal is to advocate, educate, and empower. We decided to do these virtual discussions to address topics that are important to those with sickle cell, as well as their caregivers and anyone who love them or anyone in our community who just want to learn. And if you've listened to our various chats in the past, you've learned that there are topics that are really applicable to a lot of people and to others with other chronic diseases. Our focus is on sickle cell disease and just to help to educate our community. We're so excited to see another year. We're excited to have another set of series of our Tuesday chats, and we're excited for our special guest that's joining us tonight. This is a guest that I actually I follow her myself personally, as well as the Be Strong Group on social media, and she has a wealth of good content. She's an advocate for sickle cell disease, and her name is Maya Bloomberg. She's a hematology nurse practitioner with the University of Miami Miller School of Medicine. Hey, Maya, how are you?
Hey, friends. I'm so happy to be here. I didn't know it was the first of the year, so we're kicking it off strong tonight.
Yes, you are the first, and we're so excited because you guys listen. We will be talking tonight about understanding your labs or your children's labs, and that part is really key to making sure we're managing this illness appropriate. But before we get started, I just want to remind everything you hear is for your educational purposes only. And if there's anything that's more specific to you or your child's health, please consult their specialist or primary care provider. So we wanted to add that. And Maya, again, before we dive into our topic, is there something else you want to share? I know share more about yourself, who you are.
Sure. I'll just give a little background of where my nursing career started and where I am now and why I became such a huge advocate for sickle cell, and then we'll get into the nitty-gritty of our conversation. But my nursing career, it started over 10 years ago. I was a bedside nurse at a med-surg tele hospital, and I cared for a lot of sickle cell patients, but I really only saw the pain and the anemia. I also saw tons of doctors treat patients like numbers, so when I became a nurse practitioner, I knew I wasn't so focused on what my specialty would be rather than getting connected with a doctor who truly cared about their patients. So hematology kind of fell in my lap, but it was a big blessing in disguise because look where it's brought us today. But Dr. Harrington, he is literally the biggest mentor and another huge sickle cell advocate, and you'll feel his energy is just so magnetic. You can't help but be as passionate as he is. But when I started working with him, I was treating sickle cell patients, now outpatients, and I was seeing all of the complications, my patients being mistreated in the ERs, the ones who really get hospitalized maybe once every other year. And I started to see a common trend of just mistreatment, judgment, and overall a lack of understanding and awareness of sickle cell. So I've been a big advocate in the sickle cell community, but it wasn't until February of last year, kind of in the middle of the pandemic, when we saw articles showing a really big racial and health disparity among Latinx and Black Americans with COVID specifically. And it's not because the genetic makeup increases somebody's risks of COVID and complications and hospitalizations and death. There's a whole multitude of reasons. So that kind of triggered me to see how can I use my expertise to kind of bridge this gap. And lo and behold, I have my social media page, which is how you and I got connected. And I think what you're doing is absolutely amazing. But I created my Instagram handle, the HemNP, like Hematology Nurse Practitioner. And my goal is to really just help educate patients on sickle cell, on their condition, because we know there's a national shortage of sickle cell providers. There was a survey that showed that only 20% of primary care providers felt comfortable caring for sickle cell patients. And there's just lack of understanding. So I feel like if I can help especially that transition period, young adult patients better understand their condition in easy to digest way and reliable information, I felt like that could just do a world of wonders to this community. So Happy to be here. That was a little bit of a rant, but I just want y'all to know where my passion lies and kind of what led me to get connected with you.
It's a great rant. And it's full of information. And you guys who are listening and those who are listening on replay, we're gonna make sure you get her social media contact information, because you have to follow Maya on her social media accounts, because I tell you, everything is good and valuable. And she adds a little jazz to a lot of her reels too on Instagram. So I love it. So thank
Keeping up
you
with the
for
program.
that. Yes, and we I noticed by following Maya that she had a lot of content, and she will always ask her followers, is there something that you want to know about? And one of the things that me as a mom of someone with sickle cell, and we go for our labs monthly now. It was like, okay, what does this mean? Okay, his hemoglobin has changed due to this. What does that mean? Or when I'm looking at the labs on my app from his visits, you kind of want to see or gauge where things are. So I think, and I've spoken to other parents, and they feel the same way, of wanting to know and kind of understand a little better about how to make sense of what we're seeing, instead of just focusing on two pieces of the labs, but trying to understand kind of the whole picture of what makes sense. So that's why, I reached out and said, hey, can you share some information from your perspective
And I
about.
thought it was an awesome idea. When you said it, I'm like, oh, what a great person. It really is so relevant because as providers, a lot of times not everyone is given the time. If you're particularly busy, you might not be able to break down every single thing and what it means and only focus on abnormal. So I think as a patient and as a caregiver, having just a baseline understanding of what your labs mean and how to track trends can make a big difference for picking up subtle changes in your conditions.
Absolutely. And one thing that you say quite a lot in your posts is a key part of being a good advocate or an advocate is understanding or educating yourself to the best of your ability. And this is a part of that education piece, so that we can be stronger advocates. Those who are listening who may be warriors themselves, you could be, by learning and educating yourself, you can be a stronger advocates for yourself when it comes to understanding just this piece of it. So Maya, how do you want to share this? Do you want to go into the presentation, the content that you created?
Sure. Why don't we start with that since you were the one who really was the trigger for me to make this. So let's pull up the slides and we can kind of do a breakdown. It's a lot of wording and it can get, I don't want anybody to get lost. So what I'm going to do is kind of just highlight what the important parts for each lab value that are listed here for sickle cell specifically. So this was the first part that we did, focusing on your CBC, on your complete blood count. Usually the first thing that's reported are your white blood cells. And we know our white blood cells are what fight and detect infection, and they can fluctuate a lot. So if you get your labs today and tomorrow, chances are these values are going to change from day to day. So again, it's not that important to fixate on such the minuscule changes, but it is important to understand what changes could potentially mean. So when your white cell count increases, the most common cause of this is infection. But for sickle cell, when you're in a sickle cell crisis, your body's in this pro-inflammatory state. So we see a rise in white blood cells too. However, if you have sickle cell, we know infection can trigger a bunch of different complications and issues with sickle cell, that if we see a rise in your white blood cell count, it's reasonable to rule out other causes of infection. So if you're in the hospital, for example, and they see that you have an elevated white cell count, they might do a chest x-ray, they'll check your urine, make sure you don't have a UTI or a urinary tract infection, and try to rule out other causes of an infection before just saying, oh, okay, they're having a sickle cell crisis. When you have a low white blood cell count, this is when you're at higher risk for infection. Now, some people have a condition called constitutional neutropenia, which is just, it's very common in African American ancestry and African descent, where you just always will have a low white blood cell level. It doesn't mean that you're at higher risk of infection. What happens is your white blood cells actually will be sticking to the blood vessel wall lining, so they can't get quantified when you get a blood sample. But again, if you have a low white blood cell count, you want to rule out one of the most concerning causes, which could be cancer or infection and different bone marrow issues like that. So white blood cells are really important because it can help prevent and potentially cause infection, but for sickle cell specifically, if you see a rise, it could just be you're having a crisis. Okay, let's move to the next slide. So here we have our hemoglobin and hematocrit. So as a reminder, your hemoglobin is what carries oxygen throughout your entire body and the tissues. When that oxygen detaches from the hemoglobin, that's when we see the hemoglobin S polymerization, which is the medical term for when that cell sickles in shape and forms that crescent C shape, which they're long, they're rigid, they're sticky, and they start sticking together, blocking the blood flow, which is just the first step of a vaso-occlusive crisis. So when you're seeing a drop in your hemoglobin, obviously we know that's anemia. And when we have different breakdowns of anemia, I think it's on the next slide, is the MCV, which will further go into the anemias on that one. It'll be easier. But when you see a rise in hemoglobin or hematocrit specifically, how this is important for sickle cell is if you're dehydrated. Say we have some patients, I mean, your son Brenda has hemoglobin SC, so I don't know what his baseline hemoglobin is, but I would imagine it's maybe 9 to the 12 range, maybe even higher, because we don't see that rapid hemolysis or rapid red cell breakdown that is more characteristic of hemoglobin SS subtype or S beta thal 0. So when you have patients with normal or high normal hemoglobin, it's extremely important to stay hydrated because dehydration can actually falsely make your hematocrit look higher. And the problem with high levels, especially in sickle cell, is the viscosity of your blood, which is the thickness of your blood, increases. So imagine you have a straw and you have water going through the straw. Now imagine honey going through the straw. The honey, it's much thicker. You're more likely to have sluggish blood flow and more problems with sickle cell. So this is where a teaching point is for my patients with higher hemoglobins. And for me, anything above a 10 is a high hemoglobin for a sickle cell patient. I need to stress the importance of drinking lots of fluids because that's the biggest way for you, especially with the high hemoglobins, to prevent crises. Other causes of a high hemoglobin, polycythemia vera is very common, or it's actually not very common, but it's a common condition that I treat where we have patients with high hemoglobins, and that's actually treated with hydroxyurea as well, just like sickle cell is. Testosterone supplementation can actually cause a rise. So sometimes I'll see patients with hemoglobin like well within the normal range. The treatment is to give blood, to donate blood, to remove that excess iron and excess hemoglobin. But sometimes stopping the causative factor will address that issue from the beginning. And then here you see chronic hypoxia. So this is if you have long-term, you're not getting enough oxygen. So say this is your sleep apnea patient where you might be sleeping 8 hours every single night, but you're not having good quality sleep because you're having periods where you just stop breathing. You're not getting that oxygenation. Your body's going to compensate by producing more hemoglobin because, again, your hemoglobin is what carries the oxygen. So if you produce more hemoglobin, your body thinks, okay, I'm going to have more hemoglobin circulating and more oxygen to be delivered to my tissue. So similar why cigarette smoking can cause that also. Since I spoke about sleep apnea, I just want to mention for sickle cell, say you're waking up multiple nights a week in pain. You're awoken in the middle of the night in pain. I want to check my patients and see, do they have sleep apnea or are they having drops in their oxygen level in the middle of the night, which is then triggering sickle cell pain. So there's different insights and information we can see from your labs, but also as a patient, information you can provide to us as a provider to try and see where that missing piece is to kind of improve your symptoms and your quality of life. So we'll go to the next slide, which I'll dive into the anemia a little bit further because I think it'd be easier seeing it.
Okay, and I just want to mention to everybody's listening, if you have a question, go ahead and put it in the chat, and I don't think Maya would mind answering it. Okay.
Perfect. So MCV, mean corpuscular volume, which essentially tells you the size of your red cells. When I have a patient with anemia, the number one thing I want to know is what is their MCV, because it helps me figure out in my mind, okay, is it a nutritional deficiency? Is it chronic disease or inflammation? Is it thalassemia or iron deficiency? So let's start, I'll work from the bottom and going up. So say you have a low MCV. So this is going to be an MCV under 80. You have small red blood cells. The number one cause of having a small red blood cell is iron deficiency anemia. Another cause, though, is thalassemia. Now, this is a point for any of my thalassemia patients listening in. This is like the number one way that you can advocate for yourself. Many providers will just look at a patient's CBC, they see a low MCV, maybe they see some other things like an increased RDH, and they say, oh, this person has iron deficiency, start on iron supplements. Then I'm in a follow-up appointment and I see them, they never checked an iron level. They just assumed based on some of the labs that they had iron deficiency, when in fact, this has been a long-standing problem, which means that this person has had small red blood cell size every single time we've ever checked labs or they've ever had labs checked on them, which shows a trend and more so has thalassemia than iron deficiency. Now, the teaching point for this is for patients with thalassemia, you actually hyperabsorb iron. And for a man, you have no way of getting rid of excess iron. Women, every time you have your period, you're getting rid of iron each month. But men, you have no way, unless somebody was to stab you and you're bleeding out and losing blood that way, of losing iron. And when you have blood transfusions, repeated blood transfusions, we're constantly putting more and more iron in your system, or your primary says you have iron deficiency and gave you iron supplements long-standing, and you never actually had, and you had thalassemia, all of that iron is building up in your system, and then it can deposit on any organ. It can go on your kidneys, on your liver, on your heart. It can go on your joints and cause chronic joint pain as well. So this is a big teaching point for my thalassemia patients, is that if anybody ever says, oh, you have iron deficiency, always double check, did they check an iron or a ferritin level on you? Because especially for a man, you never want to start on an iron supplement unless it's 100% proven that you have iron deficiency. And if you're a man with iron deficiency, why? That is not normal. That's totally abnormal. So you need to check, do you have prostate cancer? Do you have blood coming out of your stool? So there's different types of workups that need to be done if that were to happen. Like, you just do not accept iron deficiency in a man. So now let's move to our normal MCV. So this is a cell size between 80 to 100. Anemia of chronic disease is like the most common. Sickle cell typically is not going to affect your size of your red blood cells. I'm going to call out PNH because I know once you post this video, my patient Angela is going to listen to this, and he has sickle cell. And when he came to us, his anemia was just so impressive for his symptoms and just the degree of everything going on that when we did a second workup, we actually found that he had PNH, which is the super, super rare condition called paroxysmal nocturnal hemoglobinuria. Say that 10 times fast. Affects only 15 in a million people, but it's another condition which is characterized by rapid red cell breakdown and also has a huge risk for blood clots and a bunch of different complications associated with it. But that's a very rare condition that can be associated with actually iron deficiency, anemia, or having a normal red cell size. Now let's talk about high MCV. So that's anything greater than 100. For sickle cell, I use MCV size to know, are you taking your hydroxyurea? So when you take hydroxyurea, it stabilizes your red blood cells and it creates more fetal hemoglobin, which is what babies are born with. This is really stable and it doesn't hemolyze or break down as easily as sickled hemoglobin. And just a little fun fact, babies produce, all kids will produce fetal hemoglobin until around 6 months of age, which is when the adult hemoglobin starts to being produced. So for me, that's hemoglobin A. For others, you have hemoglobin S or hemoglobin C. So that's why we start seeing issues with sickle cell beginning between 6 to 12 months once that adult hemoglobin starts to being produced. So when you're being prescribed hydroxyurea, you want it to increase your fetal hemoglobin, help stabilize those blood cells. And part of that is it increases the size of the red cell. So if I have someone who's taking it and their MCV is normal, it's 89 or 90, I want to know, are you actually taking the medication? Because if you're, yes, Maya, I promise you I'm taking it every single day, I'm not missing a dose. Okay, great. We got to increase your dosage then, because obviously the dose you're on isn't enough for your body size. It is a weight-based medication, but I have patients who are 100 pounds taking 2,500 milligrams, and I have the opposite where I have 200 pound only taking 1,000 milligrams. So it is weight-based, but everybody metabolizes and breaks down medication differently. So that's where an individualized regimen for each patient is so important. Say you're not compliant with your medication, and then that's just a teaching point for me to come up with different strategies. And I always, if a patient's not compliant, I am not one to say, oh, patient's non-compliant, because there's usually a reason. Like, are they having side effects? Is it hard to take the medication? If you spend the time to really see why are they non-compliant, sometimes you can problem solve and figure out a way to make it work with them a little bit more. If it's a matter of forgetting your pill, I mean, I'm the worst when it came to medication. I totally empathize having to take a daily med. And for me, the easiest thing was getting those pill cases that all of our grandparents have, the Sunday, Monday, Tuesday. I left it by my toothbrush because every morning and every night I brush my teeth. So I'm pairing that with something that's already a routine for me. So I had 2 shots. So if I forgot it in the morning, I could take it at nighttime. So it's important to understand the importance of taking it regularly, because if as a provider, I thought you were taking something regularly, I see that normal MCV when in fact you aren't taking it regularly, and then I go and increase your dosage, that has the potential to cause side effects. So don't tell your providers what you think we want to hear. Be honest with us, even if it's not what we want to hear. It's for your safety at the end of the day. And if you have a provider, I don't want to generalize because I know not all providers are created equal, but a provider should work with you and try and see how they can make a certain regimen work within your life.
Okay.
So I think that's good for MCV size. If we want to next move on to platelets.
Okay. Can I show a couple of comments so far?
So I reckon another Instagram friend that I've never met in person, but I'm from Baltimore, so we clicked on the Maryland homegrown.
Yes. Very,
hematology can be so complex, and I think that's where I kind of take pride in the fact that I can simplify it, because you have the engineering background, me with my medical background. I never was the type of person to just memorize everything in school. I had to understand like what causes this, and once I figured out what the chain of events were, I didn't have to memorize it. So I feel like my way of simplifying what sickle cell is just, it's nice that you can hear it playing. Anyway. All right, if you're dehydrated, should the patient go immediately to the hospital or do different things at home? So this is kind of a general question. So the number one sign of dehydration is thirst. Usually when your body is thirsty, that's your body's first sign to you that you need to drink more water. Chapped lips is another big one. I have patients come in and like I jokingly say it's a Harrington test. Like if you have your water bottle with you, like, okay, you passed the Harrington test and you're good for this clinic day. But I'll have patients and their lips are clearly chapped and it's just so obvious they're dehydrated. There's other signs of dehydration. Like if you look at your skin and you were to just pinch it and see how my skin just bounces back really quickly. This is called your skin turgor. If you're dehydrated and you were to do that, you'll see it just like move back kind of in slow motion. And that's another big sign of being dehydrated too. So a lot of times you can manage dehydration at home as long as you're able to maintain that intake. You should be able to manage it at home. We say for normally we recommend 8 to 10 glasses of water a day. So for sickle cell, you want even more of that. And I would say that it's also important to focus on food sources of hydration too, because it's not always fun to drink water. So, I mean, if you like soup is like 99% water. You have different fruits that have a lot of water content, like watermelon and berries. You could do cucumber and salad. So there's different ways to incorporate hydration into your diet without making it difficult. The only time I would say to go to the hospital to get this managed is if you're super dehydrated because you have a gastroenteritis or a stomach bug and you can't keep anything down, or you're just vomiting everything up or pooping everything out. That's a reason for you to go to the hospital, because if you're not maintaining hydration, it's just a matter of time that your sickle cell is probably going to get triggered into a crisis or complications. And the most important thing to know when your body's dehydrated, it diverts or it reroutes your blood flow to your essential organs, which is your brain and your heart. So your kidneys get neglected, which is why we can start seeing kidney issues and other organ failure with dehydration. So I would say if you notice signs of dehydration, just start upping up that intake. And then if you're not able to maintain that adequate intake, or you start developing other symptoms, and a big red flag is like altered mental status, or if you're not passing any urine output, like that's a sign 100%. If you're not peeing in like several hours, your body's diverting and trying to hold on to as much water as possible. Constipation is another really big common symptom of dehydration, because again, all of that fluid is getting diverted to your brain and heart. So it's getting sucked right out of your poop. So you have like little tiny duty ball pebbles. Sorry to get graphic, but if you're seeing that type of stools, that's because you're dehydrated, and it's a sign to increase your fluid intake as well.
Well, that's a very good explanation and point taken and made.
Cool.
Yeah, we had one more comment from Willie. Hey, Willie. Can you see that comment?
Awesome. He worked at Johns Hopkins. So we got another Marylander. They have a great program up in Johns Hopkins. I worked with, I believe his name is Dr. Krause. We did some research studies with our institution as well. But I heard that they have a nice sickle cell program up there. Cool. So now moving on to the platelets. So normal platelet count is 140,000 to 400,000. Platelets are super important to help your blood clot. If you have too little platelets, you're going to bleed. If you have too much platelets, you're going to clot. So here you can see the spectrum. So polycythemia vera, PCV, that's another condition. Again, we pointed out on the hemoglobin that can present with high hemoglobin and also high platelet count. Different bone marrow syndromes can cause it. But a sickle cell crisis. Platelets are very unique. They're in a class of, we call it an acute phase reactant, which means that it can fluctuate. So again, if you take your platelet count today and tomorrow, chances are it's really not going to be the same because stress, infection, inflammation, all of those are going to increase your platelet count level. So again, say you're having a sickle cell crisis and you have a doctor pull a CBC and they're like, oh, your labs look normal. It doesn't look like you're in a crisis. Maybe they were looking at your white blood cell count. Maybe they were looking at your hemoglobin. Maybe they were looking at your platelets and they say, oh, well, all of these are within normal. Her platelets aren't high. I would expect to see that in a crisis. Oh, they must not be having a crisis. But on the other end of the spectrum, when you do have a sickle cell crisis, we do see that rise in your platelet count. And when you have that rise, again, it's super important to drink lots of fluids because, again, too much platelets can cause clotting issues. And sickle cell, and I'm not sure if anybody has sickle cell trait who listens on, sickle cell trait also places you at higher risk for developing blood clots. So just understanding that inflammatory state that we see in sickle cell and the potential of it causing blood clots is another reason to make sure you're drinking lots of fluids, but that we can see that rise with the crisis. When you have a low platelet count, so this is anything under 140,000, this is called thrombocytopenia. I mean, when I was pregnant, I had gestational thrombocytopenia. So there's different conditions where you can have short periods of drop in your platelet count, which again, when it's low, we get concerned of bleeding. We usually don't see we don't really start medication management for a low platelet count until you drop usually to 30, maybe 50, depending on the patient's clinical signs and symptoms, but you don't see the spontaneous bleeds or severe bleeding episodes until you're well under 30,000 platelets, at which time you're definitely going to be on therapy. And you can see the other conditions that can be affected. What I didn't include is hydroxyurea has the potential as one of the big side effects is causing bone marrow failure or bone marrow depression, where you can see a drop in your white blood cells, your platelets, your hemoglobin, and you might actually have to stop the hydroxyurea therapy for a period of time and could restart it, or they might stop it altogether depending on what that history was like. But people who have a low platelet count might not be good candidates for hydroxyurea. Every provider has their own cutoff. I think Dr. Harrington and mine is a little bit lower compared to others, but maybe if it's under 100, a provider wouldn't necessarily consider it for you. We go a little bit lower than that, but it's something to monitor when you're on hydroxyurea, just knowing that it does have the potential to drop your platelet counts as well.
Okay, I have a question.
Sure.
So with the platelet count and the drop on hydroxyurea, so is there a certain level of your platelet count prior to starting hydroxyurea? Or are you saying if it's below 100 when you have started and it's dropping too low?
So two ends. So first, if I have a patient who their baseline platelets are low at 70, hypothetical situation, I wouldn't really recommend hydroxyurea to them. It's not the most appropriate. I wouldn't want to start them on something that could potentially drop that further.
Gotcha.
Patients who are maintained on hydroxyurea, no medication has zero side effects. Even our over-the-counter medications have side effects. And this is with hydroxyurea specifically, we know what the side effects are. And because of that, we do routine blood work. For pediatrics, they might do blood work every single month. On the adult side, I do it like every 3 months. It's very specific to the patient and how often they're having issues. If they're SC, maybe it's even less frequently than that. But we check your labs frequently because we know that hydroxyurea has the potential to cause issues, and it's easier to pick up subtle changes before it becomes one. It's not like you're fine today and then tomorrow all of a sudden your platelet count just drops. It's usually a slower drop and we can pick it up. But this is where if you start feeling a little off, or if you start noticing like red dots on your skin, which is called petechiae, or could potentially be petechiae, which indicates a low platelet count, or say your periods all of a sudden are really, really heavy. Maybe you have a low platelet count that's causing more bleeding, nosebleeds, gum bleeds, or just weird bleeding symptoms that you didn't have previously. I'd want to know, okay, what's their platelet count? Let's do a CBC. So this is something where if you have any new symptoms, definitely advocate for yourself and reach out to your provider to see, hey, is this normal? And if not, what are the next steps?
Okay. You ready for the next slide?
So this one, the MCH is kind of the color of the cell. I don't really focus on this. I just threw it in I don't know why I threw it in. But when it's low or it's a paler color, this is usually iron deficiency or thalassemia. Reticulocyte count. So your retic count is reflective of immature hemoglobin that are being produced. So when your body is breaking down hemoglobin and you have anemia, your body should compensate and produce new hemoglobin. And this is what's reflected in the reticulocyte count. So if you have a low hemoglobin and you have a high retic count, this is a good sign to me because I know your body is working appropriately. And again, this is why we have our patients taking folic acid, or I actually recommend B complex vitamin, which has folic acid, B12, B6, all of those water soluble vitamins. Most people don't really need prescribed folic acid. You're going to end up peeing out the excess anyway, but it's important to give your body the nutrients that it needs to produce new red cells. So when you see that high retic count, you want to make sure that you do have enough iron, you do have enough folic acid and B12 to produce those cells. Now, say you have a low hemoglobin and a low reticulocyte count. That's concerning. Like, what is wrong with your body that you're not producing new red cells? If you have kidney function issues, your kidneys are what produce and secrete a precursor to hemoglobin called erythropoietin. And once your body detects a low hemoglobin, it'll secrete this precursor, and that's what stimulates the chain of events to produce new hemoglobin. So if you have any impairment in your kidney function, which is very common, especially an adult person with sickle cell, just having dealt with all of the years, this could potentially be contributing to worsening anemia. So we want to make sure we look at the retic count. This is another instant where if you have a provider say, oh, they're not having a crisis, they have a normal retic count. That's an instance where they're like, what are they looking at? Like, how do they know that I'm not having a crisis when I'm the one feeling all of this pain? That's another indicator. So it's possible if you have a low retic count, is it one, do you have normal hemoglobin? Because if you have SC with a hemoglobin of 12, I wouldn't really expect you to have a high retic count. But if you have a drop in your hemoglobin and low retic count, one, you want to make sure you have all of those nutrients that you need. But if you have a really low retic count, like less than 1%, there's a parvovirus I had put on the slide, which is an infection that really it just makes your body break down red blood cells and you don't produce anything, and you have to treat with repeated blood transfusions. Usually you're admitted for this. So just any subtle symptoms, if you're just feeling off, it's easy enough to get CBC run and just see what could potentially be contributing to your symptoms. I think with sickle cell, sickle cell can cause so many issues and so many symptoms that it's so easy to just blame it on sickle cell, but you're your biggest advocate. You're the one who can feel what's going on inside of your body. And if something genuinely doesn't feel right, I will always listen to my patient, and I don't see any harm. You're the one who's going to get the needle in your arm. If you want to go and do that, then by all means, I'll put the orders and see if there's anything worthwhile to explore further.
Okay. That's a lot of good information.
I'm like a chatty Cathy. I could just keep going on tangents. So I'm like trying to circle back, and because I know we still have even more. So now we're looking at the CMP, which is your comprehensive metabolic panel. This tells you about your electrolytes, kidney function, liver enzymes. I highlighted a lot on here, but I'll overview the ones that I think need more time and kind of skim through the ones that I don't think as much time. So okay. First off, we see glucose, which is obviously your source of energy, and this is what we need to really function. So if some person has drops in their blood sugar, you can start feeling like really tired, dizzy, diaphoretic, or get sweaty. And maybe it's just a matter of you needing to eat breakfast in the morning to curb these symptoms. And it's not necessarily related to your anemia for once. But if you see somebody with consistently elevated blood sugar or blood glucose levels, and it's when they're fasting, then there's the concern potentially for diabetes. But the issue for sickle cell is the test that we use to check for diabetes really isn't reliable. So we use this blood test called glycohemoglobin A1C, and it tells you your blood sugar control over 3 months. But that's because the lifespan of a normal red blood cell is 120 days. And as a reminder, a sickled hemoglobin or a sickled cell only has a lifespan of 10 to 20 days. So this test is totally worthless. I'll have patients and I'll see their whole annual from their PCP and they have an A1C of 4.5%, which anything below 6, some have less than 5.8% is what you want. So they're like all excited. They have that A1C at 4.5%, and I have to be the bearer of bad news and be like, that's probably your blood sugar control over the past month. Like that's good for this, but a more sensitive test for sickle cell could be fructosamine, which is another lab, but it still isn't giving you that rich data that an A1C would provide to me, for example, but something just to be aware of. When we look at our kidney tests, your BUN and creatinine are the waste products that come from your kidneys and muscles. And for sickle cell patients, usually we have low creatinine because sickle cell, you have an issue with concentrating your urine. So patients with kidney disease, you'll see an increase in your BUN and creatinine. Usually it's like a 10-to-1 ratio. So like a BUN of 10, a creatinine of 1. But if you start seeing that ratio get wider, so say you have a BUN of 30 and a creatinine of 1, that tells me you're dehydrated and you need more water. But if you still see that 10-to-1 increase, so say all of a sudden it's 20 with a 2 creatinine, just throwing out numbers there, that's a sign of kidney issues. But for sickle cell, again, I mentioned usually you'll have a low creatinine because you have a problem concentrating urine. So we really won't see that rise in creatinine until really, really later. So if you're having a rise in creatinine, to me, that's like, oh shit, oh shoot, there's a potential that this has been going on for a longer period of time and we need to be a little bit more aggressive. For sickle cell, one of the tests that should be done every single year for an adult patient is a microalbumin creatinine ratio. This is a urine test. You can do a urinalysis, which checks if you have protein loss. That can be an early sign of kidney damage. But an even more specific test that's going to pick it up even earlier is that microalbumin creatinine ratio. And if it's above 30, that's a sign that you have like very, very microscopic small particles of protein coming out. And that's the earliest sign of kidney dysfunction. So that's something that if your providers aren't checking already, like at a minimum, you should be getting a urinalysis. And if there's protein in there, that should be explored further. Because if it's consistent, if say we see protein one time, I'm going to say, okay, make sure you're drinking lots of fluids. Because remember, if you're dehydrated, your kidneys are getting neglected and not getting the blood flow. I'll tell you to avoid medicines that can be harmful to your kidneys. The most common one being your NSAIDs. So that's your ibuprofen, Motrin, Aleve. You want to limit using those. And then we'll recheck it in a few months and say it's improved. Awesome. Say that ratio is still just as bad despite doing those improvements, that's when I'm going to start you on a medication called either Losartan, Candesartan. There's a class called ACE or ARBs that it's a blood pressure medication, but it's never used as a single agent by itself. It's always used in combination. The reason we use it is because it dilates the vessels that enter and exit the kidney. And by doing that, decreases the pressure, decreasing the workload of the kidney, and can actually reverse kidney damage and protect from future damage. So again, another teaching point in a way that you can advocate for yourself is check, like, am I giving a urine sample at least once a year? If not, like, let me just ask my PCP if they can do this. And if you do see protein loss, okay, well, now I know I really need to drink lots of fluids. I shouldn't be taking my ibuprofen as much. And if it persists, knowing this is one of the earliest signs of kidney damage, I want to do something now before this is getting to the point of kidney failure. Because once you get to that next level, you're going to need dialysis. And sickle cell and dialysis or kidney failure, just you have two different components that are both affecting your hemoglobin. You have sickle cell, which is breaking down your hemoglobin, and now you're having kidney issues, which is affecting your production of hemoglobin. So you really want to take pride and take care of yourself during your adolescent, young adult years. I think that's the biggest time where people are maybe rebelling. They don't want to let their sickle cell identify them, and sometimes just ignoring that they have sickle cell and living their life and partying it up and doing what they want and staying away from the doctors is how they're coping with their condition. But it's important to realize the landscape of sickle cell is changing so much. I mean, I've been caring for sickle cell patients as a nurse practitioner for over 7 years now. And in the past 3 years, all of a sudden, there's so much more interest. Right now, we're getting contacted by so many different pharma companies for different research studies, for different treatments. So we're going to have so many different treatments to offer, more combination therapies. And we have that promise of the future with the cure that for my young adults, it's so important what you're doing now, because if you're 20 years old, based on the research that we're having right now, there's a very, very, very good chance you're going to get cured in that future in the sooner than later. And you don't want to deal with kidney issues or deal with avascular necrosis or pulmonary hypertension or all of these complications of sickle cell because you weren't taking care of yourself during your 20s and young adult years. So I'm preaching a little bit, but please take care of yourself, especially those young adults, because they really are precious years and can have major implications of what happens to you when you get older.
Oh, absolutely. This is such good information, and that's why it's so important for us to learn and know. And definitely, we'll be resharing this to make sure as many people as possible can hear.
So now let's move to the next slide, which is going to go over different liver tests. Okay. This is your ALT, AST, and your ALK phos. When we look at, I'm not going to go too into detail because it's just, there's different ratios and whatnot to that, but specific to sickle cell, I always say anywhere blood can travel, sickle cell can affect. So that includes the liver. So during a sickle cell crisis, we can see acute organ failure to any organ. You can see it to your kidneys, you can see it to your liver, and this will be reflected with rise in your ALT, AST, and your ALK phos. Certain, like say you're an alcoholic, we'll see a different type of ratio between ALT and AST. So I remember one time I had a patient who, she just had low white cell count. She had, everything was low on her CBC. So she was referred to hematology, and she had elevated liver enzymes, and she was saying that she does not drink at all. She had like a great story. She's undergone different bone marrow biopsies, etc. She had that elevation, which really did seem like alcohol, but we did a whole workup, and we're going to do another bone marrow biopsy. And then we see she had labs right after our appointment. And I guess the liver specialist was checking blood alcohol level at the time, and it was skyrocketed high. That it was just the first time where I couldn't believe how some people really can manipulate stories, which it's unfortunate because the number of people who really are lying or manipulating a system, it's so few. But when you look at the care for sickle cell as a whole, it's like you would think that everybody was addicted to medication and just wanting to get their next fix in the ER. And it's unfortunate that more providers don't realize that patients with sickle cell have their own lives, they have their families, they have their jobs. They don't want to come to the emergency room and have all of that disrupted. And I think when you look at the number of people who mismanage themselves or don't utilize the hospital as they should are so few that we really need to bring more awareness and compassion. So I think that's enough overview for the liver test, because that it's really just the indicators of liver damage. On your CMP, you'll see a bilirubin. If you don't mind going back one more. Bilirubin is an important one for sickle cell because when your body is breaking down hemoglobin, bilirubin is a byproduct or is a waste product. And when that level increases, that's when you start seeing yellowing of your eyes, maybe the inside of your mouth, the palms of your hand. This is called jaundice. So jaundice can either be seen in liver disease or it can be seen in sickle cell. And this is like one of the most obvious signs. I mean, sickle cell is an invisible disease, but this is one symptom you definitely cannot hide. Sometimes when you notice jaundice, that could be an early sign of your body. If you get jaundice before you start having pain, that you need to pause. Like, what am I doing right now that is causing me to have a crisis? Am I overdoing it? Have I not slept well? Have I not drank enough water? Is something stressing me out that I need to like pause and rewind and just kind of do a little bit of stress management? But sometimes that can be one of your earlier signs before progressing into a severe pain crisis where you can kind of intervene and stop that trigger if you have an identifiable one. Albumin is one I put on. It's not one that I highlight or focus too much when I'm looking at my patients' labs, but it is something else that's produced by the liver. It can increase with dehydration, but sometimes can affect with nutrition. So if we'll see drops in it, we might think maybe there's a liver or kidney problem. Elevations, significant elevations, maybe it's cancer. And if it's persistent, that's when we'll do a little bit more of a workup. But for sickle cell, it's not necessarily one that I'm always making sure to look out for, if that makes sense.
Yes. Okay.
So next here are your electrolytes. Sodium. I don't know if you guys can hear my beautiful children in the background or if I have good soundproof doors. If you can hear, I'm sorry. But sodium, you can see, is one of the electrolytes. If you drink too much fluids or say you're getting too much IV fluids in the hospital, you can get dilutional hyponatremia, which is where you have that drop in your sodium level. And with sodium, it's important not to overhydrate also, or just make sure that these levels are checked. And especially for some sickle cell patients who develop heart failure or liver disease, we can see drops in sodium, and too low can actually cause seizures. Pain medication can decrease your seizure threshold as well. So there's different things, pieces of puzzles that you have to be aware of just to advocate for yourself. So sodium, if it's low, is when it's concerning. And usually it's from too much hydration. If it's drawn, like say they drew your labs from where you're getting your IV fluids and it's really low, maybe it was affected from that. But otherwise, maybe it's an indication of heart or liver issues. Potassium is one of the most important electrolytes because too high or too low is completely life-threatening, because one of the biggest function is it's in your heart, so it can affect your heart pumping. And fun fact is a lot of patients, not patients, but a lot of inmates on death row, they actually put them, I don't know, how do you say it nicely? They'll use potassium as part of their injections in order to lead to their final death. So if you have very high potassium levels, it's very important to address this. We'll prescribe a medication that makes you poop it out, but high levels is very concerning because it can affect the conduction of your heart and create really abnormal heart rhythms that can kill you. And the same thing can happen when it's too low. So say you're having diarrhea, vomiting, certain medications, if you overdid it and you just are totally dehydrated, this can lead to drops in potassium levels. So when you're looking at that, potassium is definitely something that I'll look into. If you have kidney disease, late stage of kidney disease, just like over time, your kidney is what metabolizes everything out of your system and filters your blood. One of that is your potassium. So if your kidneys aren't working as a filter as well, it's going to keep more potassium in your blood and can raise levels. So if you have a sickle cell patient who has an elevated creatinine and an elevated potassium, this is more than likely been going on for several years.
Okay.
Moving right along. All right, so this was the third part that I did, which were different labs that were a little bit more specific to sickle cell. CBC and CMP were obviously great to cover, but I just wanted to highlight a couple more that I didn't go into. So moving on, there's different markers of hemolysis. So again, hemolysis is that medical term we use for red cell breakdown. We talked about the retic count or reticulocyte count going up in hemolysis. Platelet count can increase in hemolysis. Bilirubin increases in hemolysis, while other things that aren't picked up from the CBC and CMP could be your LDH level, which is an enzyme in the body that creates energy. So this level is going to increase anytime there's tissue damage. So during a sickle cell crisis, that increase in LDH can be a sign of a crisis. If you're having normal LDH when you're in the hospital, that could be another sign that the doctor's like, oh, they're not having a crisis. They have a normal LDH. They're not having that tissue damage. Another sign of hemolysis could be haptoglobin. So in sickle cell, I always laugh when I have a sickle cell patient who's admitted to the hospital and they order a haptoglobin, because obviously the haptoglobin is always going to be low in a sickle cell crisis. And this just confirms that the cause of the anemia is from destruction. It's not necessarily a production issue. So I guess with teaching hospitals, it's good to understand what labs should be ordered and make sure you're definitely ruling in and ruling out sickle cell being the cause of the anemia. But haptoglobin is almost always going to be low in sickle cell during a crisis. So if it's not something that's ordered, I don't want you to think that your providers are overlooking something.
Okay.
Next slide. And then ferritin. Give me 1 second. So ferritin, this is your iron stores, and this is another acute phase reactant. So I mentioned that your platelet counts as an acute phase reactant that can fluctuate with stress, infection, etc. We see the same apply for during sickle cell crisis. Your ferritin level can increase. So when I'm treating patients who are on chronic blood transfusions and I want to put them on a medication to get rid of that excess iron, I definitely track their ferritin levels, but I understand that if I have somebody who's in and out of the hospital and they're having lots of crises, that ferritin isn't necessarily going to give me an idea of the entire clinical picture if they're recovering from a crisis. I might want to repeat it when they're feeling well and see what their true level is. We obviously can use it to detect iron deficiency. So if your ferritin is low, that means if your iron is low, you obviously have iron deficiency. But if your ferritin is low too, that means like all of your backup stores, your backup folder of iron has been depleted as well. High is iron overload. So some people just have a genetic mutation that causes this called hemochromatosis. But again, there's secondary iron overload, which in sickle cell and thalassemia can be seen from the repeated blood transfusions. Now you guys can follow me. Nice leeway. Thanks for including that one. Are there any other slides, or I think we covered?
That's it. That was what you provided. So,
Perfect. So it was a lot of dense information. So I try to make it as interesting as possible for those listening and kind of try to break it down so it's a little easier to digest and for you as patients and caregivers to understand what changes and what trends you can see and what type of implications that would have. So if you want to be like a superstar, I mean, you're in engineering, I have some patients who will actually, they'll keep Excel sheets and they track their hemoglobin, and there's certain labs that they always track. So one way to advocate for yourself is knowing what is your baseline hemoglobin. Because if I have somebody who has a baseline hemoglobin of 6.5 to 7.5, when I get their labs and I see a hemoglobin of 6.5, I'm not that concerned. But say this is my first patient and they just transitioned to the adult side. They have no idea what their medical history is or what their baseline labs are, a very poor historian. And I get the first set of labs and I see that their hemoglobin 6.5. I'm a little bit more concerned because I don't know enough about this patient's history to see like, okay, was their baseline at 8 and now he's dropping to 6.5? This is a big change. So knowing what your baseline is one really big way to advocate for yourself, because in the hospitals, all too often, they want to transfuse you based on a number, where I transfuse based on how you feel. I'll discharge patients with hemoglobin of 5.5 or 5.7 who run low hemoglobins, but they're feeling better. Their symptoms have improved. They're saturating fine, so there's not an oxygenation issue. And as a patient, you know you have the right to refuse treatment. So it's okay if, say you're in the hospital and they want to give you a blood transfusion, if you feel like your symptoms are improving and they're just transfusing you because of that number, you can refuse that. And yes, I understand that maybe refusing labels you as a difficult patient, but you can say, I already have iron overload. I'm feeling my symptoms are better. Like, I don't want to further contribute to that. But then say, you know, your organs are failing, you have acute chest syndrome, or you have some other implication that really would warrant the blood transfusion. In that instance, definitely work with your providers and consider receiving the blood transfusion. But my teaching point is just that we don't always just treat based on the number. I care more about how your symptoms are and how your oxygen levels are and your labs in that instance.
So you guys, if you've been listening the entire time, if you came in midway, make sure you go and start from the beginning, because this was a wealth of good information. You got to follow her. You got to follow Maya. Maya, you want to give your well, that's your Instagram.
Oh, you just did it. Thank you.
Yeah.
So here's my Instagram. I mean, my goal is to put out information that I feel like not everybody is going to get from their hematology. And it's hard to know what information that you're finding online is true and factual and reliable. I mean, if you Google hydroxyurea, 90% of the people aren't going to want to take it because it can be really scary with the information that you read online. So I really am just trying to break down the information so you understand why. If I'm saying you should do X, Y, and Z, I want you to understand why you're doing that, and you're more likely to kind of adhere to that regimen. So everyone, you're more than welcome to DM me if you ever have any topics that ever are interest, because at the end of the day, I want to put out content that, yes, I find interesting, but that you will find most beneficial for you to be able to advocate for yourself and your health.
And I want to show Maya just a couple other comments. Thanks for explaining this. I am working now in the Cancer Institute in North Carolina, running the CBCs, CMPs, and MGs. Go, Willie.
Yeah.
Every day, some of the patients are on hydroxyurea too.
So start looking at their CBCs and you'll start noticing differences in MCV, and you'll start seeing changes, hopefully some stabilization and normalization.
Right. And we have learning how to read lab reports is so important. Every caregiver of a sickle cell patient needs to learn how to break down and understand lab reports. I totally agree.
Yes,
Totally.
that's why we are here tonight.
So Willie feels like
Awesome.
she's a medical technologist, hematologist lecturer again. She loves it.
Thanks. I'm such a nerd. Like, if you guys saw me from school, and my husband always used to make fun of me because all of my notes are like beautiful rainbows and everything. I'm like very OCD with, like, I can't have words like a line cut off. So, I mean, me making my Instagram is like me being back in school and just relaxing and making my posts all pretty. I'm very cool, let me tell you guys. So is early kidney disease reversible? So this is the instance where doing that microalbumin creatinine ratio test is really helpful. So this is if you start an ACE or an ARB like losartan or candesartan or lisinopril, anything in those class of medications, if you start it early enough, it does have the potential to reverse it. And I have had patients who I've been able to stop the medication altogether, knowing that they had this previously in their history, I check it a little bit more frequently to see if it returns. I'd rather start it sooner than later. But there are some people who we have been able to completely reverse it, either just through hydration and avoiding medications that are harmful to the kidneys, or having a short-term use of this medication to help protect the kidneys further. We call it renal protection, kidney protection.
Okay. Thank you for that. This is very enlightening from Brianna. This is why I love my job as a medical laboratory scientist technologist. Hey, really?
I see you taking that even further.
Everybody agrees with me. This has been awesome.
Thanks, guys.
The Excel spreadsheet is a great idea. Keeping up. So thank you, Maya. We appreciate you joining us tonight, spending so much of your time sharing about understanding our labs, and we look forward to having you as a guest in the future.
Awesome.
Is there anything else you wanted to share or remind the listeners?
I would honestly just say educate yourself as much as possible on your condition. That really is the number one way that you can advocate for yourself. I think a lot of times it can be intimidating to find your voice and be your own advocate, and can be intimidating sometimes to speak to providers. But once you find your voice, it really is enlightening and empowering. And I think that you are the one experiencing your symptoms and can pick up the earliest changes. So just speak up if you feel like something's not right. I don't feel like you should be ashamed of your condition. You didn't choose to have sickle cell. You were born with it. We could go on so many different topics of mental health and just ways, different accommodations and things to do with the employer. I mean, I know we wanted to talk about COVID just based on there's so many relevant topics, but I just think the number one thing that you can do for advocating is just continue to educate and stand up for yourself, and don't feel nervous or scared to use your voice, because at the end of the day, it's your health.
Oh, absolutely. And I just wanted to, I'm just showing a couple of other thank yous. But make sure you follow. Make sure you follow Maya, because there's also some good content she has about advocacy, about advocating for yourself and about advocating for your warrior. And it's good information, and a lot of it that was really helpful to me, given our most recent experience of, I never will stop learning. I'm going to continue to learn as I can. And and this is the good part of being an advocate and being in this realm and meeting people like Maya and a lot of the people listening this evening. I've met some wonderful people, and learning from each other. That's how we do it. We're stronger together. I know we say that a lot. Definitely. Again, thank you everybody who's listening. Thank you for joining us on our first Tuesday chat of 2022. We will be back. I'm excited because we have some additional special guests coming, sharing a wealth of information. You guys have seen our save the date for our next 5th annual birthday bash and blood drive, March 26th. So go ahead and sign up. The line to donate blood is already open, so you can do that. So keep following us. We will share. We're going to share more things from Maya, but you can follow her too on Instagram and Twitter, and to get some good information. But thank you again for listening, and we will see you next time. Good night, everybody.